Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Loss of vision is associated with a range of physical and mental health problems, including elevated risk for hip fractures and depression. In the absence of vision insurance, out-of-pocket expenses for eye exams and glasses can be prohibitively expensive, especially for people with low or moderate incomes. In the Medicaid program, vision benefits for adults are considered to be an optional service. So do states elect to cover adult vision benefits? And when they do, how comprehensive is that coverage? These are the topics of today's episode of A Health Podyssey. I'm here with Brandy Lipton, Associate Professor of Health, Society, and Behavior at the University of California, Irvine. Dr. Lipton and co-authors published a paper in the August 2024 issue of Health Affairs examining state Medicaid policies for coverage of adult vision services. They found significant gaps in coverage, which we'll discuss today. Dr. Lipton, welcome to the program.
Thanks so much for having me, Alan.
It's so great to have you here to discuss an important topic that I don't think gets nearly as much attention as it warrants. There are certain benefits that we sort of take as a given, but in fact, they are optional. So let's start with just sort of laying the foundation here. Why is it important, particularly for people enrolled in Medicaid, to have coverage for vision services?
Yeah, thanks so much for the great question, Alan. Before we begin, I'd just like to acknowledge my great co-authors on this paper, Jenna Garcia, Michael Boudreau, Petros Sazachan, and Melissa McInerney, as well as our funder, the National Eye Institute. So I think you hit on a couple of really key points already in terms of why this coverage is important, and particularly for people who are income eligible for Medicaid. So a recent KFF poll suggested that about 25% of all adults delayed or didn't get vision services in the past year due to cost, which is pretty high. It's actually one of the highest unmet needs. And that's not even for the Medicaid population, who would tend to have fewer resources to be able to afford glasses and routine eye exams. So for a person who's living under the poverty line, a pair of glasses could constitute about a third of their monthly income. So when you think about that, a person might be making some difficult choices about housing and food and other necessary costs to survive versus getting eyeglasses so that they can see. So it's a difficult cost for people eligible for Medicaid to afford. And as you said, eyesight is so integral to quality of life, right? We know it's associated with mental health, physical health, fall-related injuries and accidents, and just kind of general overall well-being, ability to interact with people.
So that one third of income is really eye-popping. The thought that you'd have to set aside such a large share of your very limited resources to cover such a basic healthcare service is quite notable. Now, I think when people think of Medicaid, they sort of assume vision is covered, but that's not quite right. So tell us, who does Medicaid cover with vision services, and who maybe do states have a choice whether or not they'll cover?
Yeah, great question. So under the Early and Periodic Screening, Diagnostic, and Treatment Benefit, or EPSDT for short, all state Medicaid programs do cover routine vision services, including eyeglasses for children and adults up to age 20. For adults ages 21 and older, vision services are completely an optional benefit. There's no minimum coverage requirement. So, the focus of our research was really on routine services, meaning, going for an eye exam just to get a check and to make sure that your vision is okay, as well as eyeglasses to correct your vision. But in terms of, what we kind of saw at pretty much all states do cover emergency eye care, treatment for eye disease, and glasses if you've had cataract surgery recently. But some states don't cover the routine vision care.
So that's a really important distinction. This often happens in healthcare. Sort of if you have a very high-end need, it's under the medical benefit and they figure out a way to cover it. But you're talking about sort of basic eye care services, and that's where it's optional to the states. So when you're looking at states' coverage, we often talk in insurance about sort of more generous or less generous. How do you think about that when you're thinking about these sort of routine services? What would be a high level of coverage? What would be a very limited level of coverage?
That's a great question. And I think it can get pretty complicated pretty quickly, actually. So we focused in terms of routine eye exams and glasses for vision correction. We looked at, how often are people able to get those services? And that did vary quite a bit in states that covered those services. So it could be every year, or even just as often as needed, or it could be every 5 years, or in one really extreme case in Maine, they actually covered one pair of glasses per lifetime, and only if you had a really, really high vision correction need. So definitely in terms of the frequency that a person could get those services, as well as whether there was a copay associated with exams and glasses. Typically, those copays, if they were there, would be small, something in the range of $1 to $3, but that could still be a barrier for people to get those services. We also looked at, did they replace glasses if they were lost or broken, not just because your vision changed. We looked at, whether there was a specific requirement, like in Maine, it was a 10 diopter, which is super high vision correction requirement in order to get glasses. But in other states, it was a lot smaller, but there was some requirement, kind of not just at the discretion of your optometrist or ophthalmologist. And finally, we looked at coverage of low vision aids, which is kind of a separate topic from routine glasses. Some people aren't able to have their vision corrected with regular eyeglasses. That's kind of the minority. Most people can, but for those who can't, there are other options like magnifiers, loops, telescopic devices or lenses that can be attached to your glasses. So we looked at whether states covered those as well.
I think it's easy to forget how complicated eye needs can be and how many different dimensions they are. Before we go further, I do just want to reflect on the population we're talking about. We talk about adults, and of course, they're two quite different, loosely speaking, two quite different categories of adults on Medicaid. They're sort of the low income, particularly expansion populations that we talk about a lot with the Affordable Care Act. But there are a lot of people with disabilities and elders that are covered up, well up into the age span. And so when we think about the need for eye services and the populations, we're talking not just about a bunch of young adults who might have a small correction, but people who are facing a lifetime of potential eye needs.
Absolutely. So I think, as you said, we often think about people who are 65 and older being covered under the Medicare program. But we have a substantial population of dual eligibles, or those who are covered under both Medicaid and Medicare. And traditional Medicare doesn't actually cover routine vision services. So some Medicare enrollees may have that coverage if they're in a Medicare Advantage plan, but traditional Medicare doesn't. And so many dual eligibles might only be able to get that coverage through Medicaid if their state offers it.
Okay, so let's turn to the findings. You did a lot of work to gather information about how coverage varies across states. And of course, anyone who works in Medicaid is aware that most people are in a managed care plan. So start giving us just sort of a feel for this. How comprehensive was coverage for fee-for-service Medicaid when you look across the states?
And that's a really good point, Alan, about managed care. I think that was kind of one of the motivations for our work here, because we know now that around 75% of Medicaid enrollees are in a managed care plan versus in the fee-for-service plan. And we wanted to know, okay, states have these policies, in their fee-for-service programs. Are the managed care plans following along with those policies or not? So that was kind of an open question for us. We really didn't know. But kind of going back to the fee-for-service coverage, most states did cover eye exams, and many states covered eyeglasses as well. So 31 states covered routine eyeglasses, 20 states did not. But the kind of most common coverage arrangement there in terms of exam and glasses coverage was to cover those services every other year. So that was about 19 states that covered exams and glasses every other year. But the second most common was to not have routine exam and glasses coverage. That was about 12 states. So, I think that on the positive side, many states were covering these services, but there were definitely some gaps, as you suggested earlier.
And then when you look at managed care, the picture is more complicated because in any given state, there are multiple plans, or there may be multiple plans. So how did you look at the managed care coverage, and what did you find there?
We thought a bit about this, and we decided that we wanted to examine more than one plan per state, because a second question that we had is, in addition to, are the managed care plans following along with the fee-for-service policies? Our second question follow-up was, are managed care plans doing the same thing within a state, or is it possible that they're behaving differently in terms of the vision services that they offer? So our kind of first priority was, okay, Let's look through the enrollee handbooks of the kind of two largest managed care plans in each state, assuming that the state had comprehensive managed care. And then we checked to see, okay, did they cover routine exams and classes, kind of to what extent, and did this sort of match up with the state fee-for-service policy? By and large, we found that, when the state fee-for-service policy was to cover routine vision care, the managed care plans did as well. So there were a few exceptions. I think there was only one state where the fee-for-service policy was to cover glasses, but the managed care plan did not. That was in North Dakota. But in general, managed care plans were covering the services when the fee-for-service policy was to do so. But then there were some instances where the managed care plans were actually more generous than the fee-for-service policy, which we thought was kind of interesting. So we kind of looked at, since we were looking at two plans in every state, did both plans provide sort of complete coverage for glasses? Did one plan do it? Or did neither? Did they provide partial coverage in the sense of giving, usually it was like $100 toward the cost of glasses correction instead of just covering kind of the full cost, whatever that might be. And so effectively in three states where there was no fee-for-service coverage of glasses, both managed care plans in the state provided full coverage of glasses. And then there were a few other cases where there was no fee-for-service coverage, but there was at least partial coverage in managed care. So in general, the managed care plans were a little bit more generous. We also saw a handful of instances where the two largest managed care plans in the state were doing things differently. Like one was providing routine vision services and the other wasn't, or one was providing more partial coverage and the other more full. So there was some variation there too, which we thought was interesting.
Yeah, I think about, you mentioned Medicare Advantage earlier. So, of course, these supplemental benefits are a marketing tool in Medicare where you say, hey, come join us. You get out from, you have to deal with the hassles of not being in fee-for-service, but we can offer you these additional benefits. Of course, the payment structures in MA are totally different than in Medicaid, but you can see the notion that there would be a different approach to this from a marketing perspective for managed care companies.
Yeah, that's kind of our hypothesis too, but it would be interesting to learn more about that.
Yep. Well, I want to talk to you sort of about how this all rolls up from the enrollee perspective and what we might want to do about that. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Brandy Lipton about Medicaid programs coverage of routine eye services, exams, and glasses and the like. Thus far, we've sort of gotten the lay of the land in terms of most states requiring coverage, but a significant number not. And then most managed care plans, the largest ones, which are the ones you focused on, following sort of along with the state, maybe offering a little bit more than what the fee-for-service programs do. So, of course, states are the unit of analysis when you're thinking about the Medicaid program, because each state sets its own policy. But states are different in size and composition. And so let's sort of look at this question from the other direction, which is, we have tens of millions of people on the Medicaid program, and they face different coverage policies with respect to vision benefits. How does it sort of add up if you look at this from more of a population level?
Yeah, thanks, Alan. So just a standard disclaimer that these are estimates and sort of approximate numbers here, but we did look at this. So we calculated that around 48 million adult enrollees had routine exam coverage, right? And that was most states that were providing the coverage. And that ended up being about 88% of enrollees. So vast majority of adult enrollees with routine exam coverage, at least for the recent period that we studied. In terms of routine glasses coverage for vision correction, we found about 39 million people, adult Medicaid enrollees, had coverage for routine glasses, and that came out to be about 72% of adult Medicaid enrollees. So even though 20 states weren't covering routine glasses coverage, they were smaller population states, right? And so it is, the majority of people who have this coverage, those still, 28% or so of adult Medicaid enrollees that didn't have routine glasses coverage.
So it's the good news is that the ratio of population is more favorable than the ratio of states. But the bad news is there's still an awful lot of people who don't have these benefits. So where do we go with this? I mean, these are really great descriptive data, really important whenever we're looking at policy. Starting with this kind of descriptive information is critical. Where does this work take you?
Oh, that's a good question. So this is part of a larger project. So we are currently interested in how these policies might impact access to eye care, as well as fall-related injuries and accidents among the dual eligible population. So again, people who are enrolled in both Medicaid and Medicare and might not have routine vision coverage through Medicare. And so kind of how do these state Medicaid policies that provide these services affect those folks?
So that's a great point, that once you have the descriptive data that you've collected, which is a lot of work, it's possible to start asking questions about the correlation between these policies and various outcomes that we might care about. And that could be very powerful information. I was thinking about, on the managed care side, we think of sort of two reasons to offer these kinds of benefits. One is the one we've discussed, which is the marketing, but the other is the cost savings. If you could actually generate from a population basis evidence, I'm not saying, I don't want to prejudge the findings, but if you did find evidence that this sort of coverage actually reduced some downstream physical or mental health costs, probably the cost of these services is quite low relative to those costs, and it might be possible to convince plans and states to change their policies on the basis of actually anticipated savings. That would be really powerful if the data turned out that way.
Yeah, I think that's how we've thought about it as well. These services are really expensive, potentially from a Medicaid enrollee's perspective, but not necessarily so expensive from a plan's perspective or from the state's perspective, if, as you said, they can generate cost savings. So we're still working on that piece, but we do know from previous research on adults under age 65 that Medicaid vision benefits can increase full-time work and potentially help people to transition to higher paying occupations. And so when we kind of looked at that among that younger population versus the cost of glasses, sort of a rough calculation suggested that these benefits might be worth providing just on that basis. So I think this would be further evidence, particularly for the older adult population who might not be working as much, that that this might be kind of an important health benefits.
Yeah, so that's a great point, that you can have health benefits, but you can also have other social benefits and income benefits that could be very appealing to policymakers. Well, speaking of policy, what do you see on the policy side here? I mean, at the moment, this is a state choice. You've alluded to the absence of coverage in Medicare. So I just wondered what you view as the policy implications of the results of your work.
It's interesting, Alan. So in some previous work, we had looked at an earlier period from 2002 to 2013. And there, we saw kind of more state action in terms of states dropping benefits, sometimes adding benefits, often dropping benefits around sort of recession times because they are optional. And so states may choose to kind of cut these optional benefits first when they need to. But, we're still completing our sort of longitudinal policy collection. This study was really focused on current policies, but we haven't seen as much action, at least in terms of just, whether a state has or does not have routine exam and glasses coverage in more recent years. A couple of states have made changes, but not as many. And I think that's something we're interested in as well. How do states make these decisions? We sort of hypothesize it's partly around budgetary conditions. Anecdotally, I think we've seen sometimes state policymakers mention possible employment benefits or productivity benefits. And so, I think that's the question that we have as well. How are states making these decisions? The fact is that, currently many states do provide benefits, which I think is positive, and hopefully kind of building the evidence base further on the benefits of this coverage could impact other states as well in terms of their decision making.
Well, that sounds exactly right. Having run a Medicaid agency in Colorado many decades ago, I can assure you that budgets play a big role. But as you also mentioned, the goal of people finding employment, it drives policy as well, and the potential health payoffs. It'll also be interesting, I think you characterized the sort of more comprehensive and more restrictive policies. And it may be that one thing that happens over time is that states start realizing that they have opportunities to move from an every other year to an every year if that actually reveals benefits as well, or something along those lines.
Yeah, no, that's a great point, Alan. I think, I didn't mention kind of our findings on copays and low vision aids earlier, but most programs that provided routine vision benefits did require a copay with their services. I think it was about 2/3 of the states that provided the benefit. So that was, I'm not quite sure what to expect there a priori, but that was the majority. So, how much that affects the use of those services among Medicaid enrollees is a question, I think, that's important. And, also low vision aids, some of those devices are relatively inexpensive, but a lot of states, the majority of states, didn't provide coverage of them, which could be particularly important for the older adult population. So I think even though the majority of states are covering some routine vision services, there are possible tweaks that even they could consider to increase the use of those services.
Well, thank you, Dr. Lipton, for focusing our attention on such a critical issue, one that does not get, I believe, a lot of attention in the health policy discussions, but is highly consequential for the enrollees who do or do not have access to this very basic service, and providing us with critical information about what states are doing, which can then serve as a foundation for additional analysis that will hopefully show us the way on what their true value is, and potentially, of course, that will feed back into the policy discussion. So we're thrilled to be able to publish the paper, and today it's my pleasure to have had you as my guest on A Health Podyssey.
Thank you so much, Alan. I really enjoyed speaking with you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.